We'll have last session in this symposium. How I would do it, I think Dr. Patnaik will present his interesting case.
Good evening, Chairperson, my dear colleagues. This is a 40-year-old gentleman who had anterior MI 1 year back, and he had ventricular septal rupture and triple vessel disease. So he underwent CABG with patch closure of VSD, and he was discharged in a very stable condition. But after 3 months, he presented with heart failure, and there was a long systolic murmur, and we did a detailed echo, which has shown that the patch has given way. You can see that at the apex, there is a small VSD, dehiscence of the patch. That is the flow across, and we found that the VSD size was 8 millimeters, and he refused another surgery. So we have taken up device closure. This is the LV angiogram. We tried to locate the VSD precisely, and it was actually 8 millimeters apico posteriorly placed, and it had significant left to right shunt. And the hardware chosen was CardioFix muscular VSD device 10 millimeters and a exchange length thermowire and Amplager gooseneck snare for the arteriovenous looping. You can see that the looping is done from left femoral artery to the right jugular vein. It was snared out through the VSD, and when the tip of the wire entered the main pulmonary artery, it was snared. The snare was used to catch it and gently drag through the right jugular vein. Once the loop is well established, we have introduced the sheath, which is 10 French Amplager. Actually, it is ASD device sheath. For want of proper sheath, we had to compromise with the selection of the sheath. That's the loop there. And we could introduce the sheath gently. You can see that at the tip of the sheath, the anatomy was not very suitable for a smooth curve into the left ventricular cavity. So a little manipulation had to be done to make it a little aligned properly. And once we are sure that the tip of the sheath is properly aligned, we have deployed the device carefully with check angios in the left ventricle. That's the left ventricular disc which is released first. Once we are sure it is properly placed, we have gradually deployed the other disc. And that is the final result. There was a trivial residual shunt which actually disappeared on 3-month follow-up. On echocardiogram, there was no shunt any further. The highlights of this case is, one is it's a post-operative patch dehiscence. So the anatomy and size are not precisely, but one good thing about it is the edges are now no longer friable like acute MI situation. And we have used a thermowire, and we have used a right coronary catheter for introducing going through the VSD. Literature says you can use balloon tipped catheter and doing the snaring. And here we have used ASD device delivery sheath instead of a specific VSD sheath, and we have not used any TE guidance. There is only trivial residual shunt on echo, and the patient is doing well. Thank you.
Thank you, Patnaik. Of course, there are very few audience. Any present audience have any queries regarding this case? See, this is the usual thing because of most of the surgeons have this fear of taking acute MI VSD because of this friable margins. They like to give away during post-surgery the patch dehiscence. So that's why if the patient is stable, we would like to take after 3-4 weeks when the MI margins get adequately delineated so that they can make with a viable and a necrosed margin. So the suturing will be perfect. But nowadays more and more percutaneous VSD closures are being done in both in acute and stable patients. And anything? Okay, right. Thank you very much. And thanks audience who are left over for their patient hearing and waiting for all the time. Thank you very much.